This is a case I recently saw here at Einstein Medical Center. The patient is a 59-year-old African American female. She has been experiencing throbbing pain for the past 3 months, rating it 8 out of 10 on the pain scale. The pain has somewhat alleviated recently thanks to antibiotics prescribed by her general practitioner. She was referred to us at Einstein for endodontic therapy due to a suspect tooth infection. She does not smoke or drink alcohol. Her medical history includes controlled high blood pressure and recent spine surgery for a herniated disc. Clinical findings. The patient came in for the initiation of the root canal therapy on tooth number 30. After reviewing her medical history, we proceeded with a CBCT scan. The scan revealed an extensive, irregularly shaped, non-corticated, low-density area extending from the apical aspect of the mesial and distal roots to the furcation region of tooth number 30, including perforation of the buccal cortical plate without expansion. Clinically, the tooth had a large amalgam restoration and shows no response to cold stimuli. Since we use lasers here at Einstein, protective eyewear was used by both the patient and staff during the procedure. After successfully administering anesthesia, the procedure started. We placed the tooth under rubber dam isolation, removed the amalgam restoration, and detect a distal crack upon access. Continuous drainage was noted from the distal canal, managed by copious irrigation using the Photona laser system at 2.5 sodium hypochlorite and 17% EDTA. Typically, we irrigate canals for about 30 seconds using each solution. The laser irrigation protocol we use here at Einstein starts with coronal conditioning in chamber using the Photona laser light walker system with a Sweets mode at 20 millijoules, 15 Hertz, and 0.3 watts power. Water and air on it. The hypo solution is activated with the laser without air and water, using the same settings for each canal. Instrumentation step for about 30 seconds. So we start with the Z1 file followed by 30 seconds activation. The Z2 file followed for 30 seconds activation of hypo, and the Z3 file on the mesial canals followed by 30 seconds activation. On the distal canal, we used a 1504 followed by laser activation for 30 seconds, and after that we finish it with a shaper for 30 seconds as well on laser activation. After hypo, we do a 30 seconds activation of EDTA followed by a 30 seconds activation of hypo and a final rinse with air and water on. Despite our efforts, the presence of a distal crack necessitated a recommendation for the tooth extraction, which was performed by a GPR resident. The patient was discharged in good condition.
I received the specimen from Einstein informal and intact, and we took various pictures of it before sectioning it. The distal angle shows the root fracture or crown fracture. Did not appear to extend beyond the cementum junction. Occlusally, that was the size of the axis, and then looking at it from the apical direction, you can get a sense of the anatomy of the canals. Our x-rays showed that there was some calcium hydroxide placed into the tooth, although not all the way down. We're going to look at mostly the distal root, and I'm going to leave the mesial root for your interpretation. This is a sagittal section of the distal root, and when you look at this, you can see there is some necrotic pulp tissue, quite a bit actually, still present within the root. And we're going to look carefully at this necrotic tissue. It was pretty extensive, and the apical part of the root was filled with pulpal debris and instrumentation debris. And we'll take a look a little look at that as well. When the specimen was dried, the pulpal tissue precipitates and you get this white type material. And when we went in and did an SEM analysis, we'll look at several areas here that I stitched together. So the first area we're going to look at is the terminal area, and we'll look for an area that maybe has an dentinal wall still kind of exposed among all the debris that's there. And if you look carefully as you go through these from the website, you'll find areas where you can actually see the naked canal wall. And in this particular case near the terminus, it looks like, to me, very robust biofilm present. Some demineralization has taken place, but you see many bacterial morphotypes all up against the wall, and the predentin, it looks like, has not been completely removed, but you can see the bacterial morphotypes there. It's pretty extensive biofilm present. And looking in other areas in the distal root, further up, more towards where the necrotic pulpal tissue was, you can see where it's kind of pulled away from the axial wall. And so you'll have an opportunity to look at the demineralizing dentinal wall there next to the necrotic pulp tissue. And when you go into that area, you can see kind of the fibrous nature of the remaining pulp. But on that layer, you can see quite a few bacterial morphotypes, as well as the demineralizing part of the predentin is still present there. So it's good to refine your pattern recognition because they can mimic bacterial morphotypes, but the circular objects are demineralizing predentin as well as bacterial morphotypes as well in the same area. So it's worthwhile spending some time going through these on your own and seeing what you can identify. We'll look at another area here near the border, in the other half of the sagittal section. There's an area that's where you can actually examine the dentinal axial wall, and in that area you'll be able to find many areas that give certainly the appearance of a candida kind of impregnation, where you're looking at the partially demineralized part of the predentin, but on top of that is this candida appearing area. And if you spend some time, you'll find quite a few of these areas against the dentinal wall there. There you can kind of get a sense of the budding. I have included some literature on that reviews kind of the pleomorphic nature of candida infections. And as an exercise, I'd like you to kind of look at these and give me your opinion on what you think these structures are. On the other half of the distal wall, the area has been indicated there where you're actually looking. And when you go in and look at all the debris against the canal wall, you'll go into these areas, and if you examine them very carefully, you'll get these structures. And so the pop quiz is, what do you think these structures are? Are they demineralizing predentin, or are they bacterial or fungal morphotypes? So I hope we can have a discussion on what it is you think you're seeing here. And then on the MIE forum, we can have a discussion about this. So thank you, Bruno, for sending the case over. A very interesting case, and I hope it generates some discussion.